Okay, so this was a National Institutes of Health. You know, people say, what are health disparities? This is what the National Institutes of Health said health disparities were. It's a definition that I don't like, and I'll tell you why in a second, but I'll read it to you. Differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups in the United States. So these things exist. There's no context. There's no explanation as to how they got there, where they're going, how we get rid of them. They just exist. I used to like to joke that, you know, on my way to work this morning, I was walking across the street and something darted out in front of me and I almost fell over it, and I was like, what the hell was that? And the person I was working with said, oh, that's a health disparity. You never know when you're going to run into one. They're just out there. Well, I grew up in Canada playing hockey, like Larry, and they use a slightly different definition in Canada. It's just a different concept, and it's the notion of inequities. And they define inequities as material, social, gender, racial, income, and other social and economic inequalities, and this is the important part, that are beyond the control of individuals. So it's not just about individual responsibility, and are therefore considered unfair and unjust. So they introduce at the outset this concept of social justice, that there's something that we need to do to make this right. The World Health Organization has taken this further, coined the concept of health inequities, which are differences in health status and mortality rates across population groups that are, and I love this definition because it just encapsulates everything that you're going to see in the slides to come, that are systemic, meaning that there are patterns to them, they're avoidable, i.e. preventable, they're unfair and unjust. So they implicate concepts of justice. So right there, the notion of working on health inequities is just more stimulating because you're working for justice, you're looking for patterns, you're trying to prevent things, whereas health disparities are just these things that exist. So they don't really offer you much of a roadmap for addressing them. Okay, so that big framework thing that I showed you before is simplified into 6 boxes called BARHI, which is another one of our favorite acronyms. We like acronyms in public health. BARHI stands for Bay Area Regional Health Inequities Initiative. And this is a group of now 11 Bay Area health departments that have come together, as I mentioned, out of frustration to try to figure out how to do better at solving some of these problems. So I'm just going to take you through it. And it's like Chinese, you read it from right to left, despite the fact that the arrows go from left to right. So the first box, or the last box, is really death. And in public health, we are essentially death experts. And you know, we don't like to admit it, but we know a lot about death. Probably more than you want to know, but you're going to hear about it. So we study infant mortality, we look at life expectancy, and we can measure these things with a death certificate. And you know, in most civilized countries, you don't get out of life without one of these things. And as I used to like to say, and Larry no doubt says in Marin, you're not dead until he says you're dead. Literally, because he has to sign your death certificate. And without his signature on it, you can't be buried, you can't be cremated, you can't be otherwise disposed of. So if you want to die and get it done with, make sure you're nice to Larry. Now, from the death certificate, you can tell what somebody died of. You can tell how old they were when they died. You can tell what their race, ethnicity was, and where they lived. And those 4 data elements are critical data elements. And I'll pause for just a brief second to tell you that this may seem like a kind of a morbid fascination that public health has with death. This is one of the most comprehensive and useful data sets we have available to us in the entirety of health practice. It's tracking how people die, where they died, and the patterns of those deaths. We underutilize this drastically. And maybe it's because it's about death and it's like scary and ooey or something, but this tells us a lot. So in Alameda County, we actually took 400,000 death certificates over about 45 years and analyzed them. We found out, nothing surprising here, that the most common causes of death are actually bread and butter things like heart disease, cancer, stroke, injuries, and smoking-related lung disease. The top 2, cancer and cardiovascular disease. are over 50%. So no surprise there, very similar here in Marin, similar to the state as a whole and the nation as a whole. We did something else that was a little bit unusual that not a lot of people have done, and I've been encouraging people to do because it's very doable, is that we went back in time and we looked at life expectancy for different populations. Now when you do this, unfortunately, you can only look at two racial groups, and the reason we look at racial groups at all is because it's on the death certificate. If we had income information or if we had educational attainment, actually, which is on the death certificate, but it's not very good, we could actually look at life expectancy by education, life expectancy by income, but we don't have good data there. But we do have relatively good data on race. Now, in order to do this, to calculate a life expectancy, you have to use the census as well. And the problem is the census only started talking about other than white and black really in 1990. Started a little bit in 1980, but it wasn't really until 1990 it started talking about all of the various racial groups that we're familiar with talking about today in terms of using data. So if you want to go back before 1990, which we did, we wanted to go back as far as we could. You can only do white, black, and other. And other is a category that is kind of meaningless because it's everybody else who's not white or black, presumably. So we went back to the 1950s, into the 50s, and we looked at life expectancy between white and black, and we saw that in the 1950s, actually, there was no gap between life expectancy for African Americans and whites in Alameda County. In 1960, the gap had grown to about 2.3 years. 20 years later, it had more than doubled to almost 5 years. And then 45 years later, it was almost 8 years. And this was very surprising to us because in our minds, we thought things must be getting better, right? We've got better medical technology, pharmaceutical technology, healthcare has advanced so much over this period of time. Yet despite that, you see this widening gap between white and black in Alameda County. Now, you'll note that both of these lines are going up, meaning that life expectancy is increasing for both populations. But it's not increasing at the same rates. And it's important that we understand why that is, because remember the first goal of Healthy People 2010 is to increase life expectancy for all populations. You could argue, hey, that's actually happening. But if you look at goal number 2, it's to eliminate health disparities. And that is growing. And it's growing pretty fast, which is shocking and definitely an alarm for those who think that we're in the business of actually trying to improve the quality of life and health status of people. So we sat around in a room, we said, well, what could explain that? And somebody said, well, it's HIV, obviously, stupid. And somebody else said, oh, it's homicide, you idiot. So we said, okay, well, let's subtract out homicide and HIV. And let's subtract out a combination of homicide and HIV. And that's what we did in this graphic. And in fact, it makes a slight difference, but doesn't make a substantial difference. The bulk of that gap is chronic disease. It's heart disease, it's cancer, it's stroke. It's the things that are killing everybody in Alameda County. It's just killing African Americans earlier and making them sicker longer in their lives. So nothing exotic. There isn't some Martian disease that's afflicting African Americans. This is about bread and butter health. Okay, so we knew we had a big gap and growing gap in life expectancy, and we knew it was driven by chronic disease. So, of course, we have to look at these factors, chronic disease, infectious disease, injury, and then the question comes up, which always comes up in these conversations, well, this is genes, man. There's nothing you can do about it. Which, of course, is not a logical thing to say because there's more variation within race than there is between race, so it's not even a plausible explanation for these differences, but nonetheless, you have to entertain it because, I don't know why we have to entertain it, but we have to entertain it. So you look at the literature, and the literature, has an answer. And, if you sat around in a room like this, perhaps somebody would say, oh, it's, 50% of the explanation. Somebody else would say it's 80% of the explanation. Some of the knowledgeable ones would say, well, probably not so much. The literature actually says it's about 10 to 15%. So what that means is that genes do matter. If you have a family history of, for instance, Tay-Sachs disease, or sickle cell anemia, or familial hypercholesterolemia, your likelihood of living long is decreased somewhat. But it doesn't explain the differential distribution of life expectancies in the population, and it certainly doesn't explain the change, that growing gap in life expectancy, rapidly changing gap in life expectancy over time. Well, then, of course, somebody says, well, it's about access to healthcare. And this is what I used to say for probably most of my early career, because I thought I was from Canada. And, you know, we have universal healthcare there, and we don't here yet. And it just seems stupid to me. So I figured that, you know, the difference has got to be the lack of access to healthcare. Well, the literature actually suggests that I was wrong, and that most of us are wrong. Most people do not know this. Those people who do know it generally spend 2-3 years trying to disprove it until they can't anymore. And that's, the evidence of that is that this study gets repeated every decade, and the same conclusion comes out. And then somebody goes to NIH and asks for another grant to try to disprove it, and they can't. So this is the research. This is my research, and I always say to people who don't believe me, where's your data? Because I just like to know upon what are you basing your conclusions. Healthcare is necessary, but it is not sufficient to deliver health. Okay, so then in the typical paradigm we talk about behavior, what people do to themselves, whether they smoke, how well they eat, whether they exercise, whether they duck when the bullets are flying. And we call this basically individual behavior. And we figure we can change that by changing what people know. So in public health, I joke, you can tell a public health department anywhere in the country because they have a room that's dedicated to brochures. And you open the door and you get, like, you know, just buried under brochures from the 1980s telling people not to smoke, to eat right, and to exercise. And we just change the colors and make them glossy, but they're the same brochures saying the same thing year in, year out. And that's actually what we get paid to do in public health quite a bit. This concept is really the medical model, is that health is really about individual behavior. You change it one person at a time. You try to change the way people interact with their environment. You give them information. That reduces their risk of premature disease and injury, which reduces their risk of premature death. And I went to Johns Hopkins Medical School. At the time, it cost me about $100,000. And this is what I learned about public health. So I've just given you a Johns Hopkins medical education in 5 seconds for free. So you got something out of this. But this concept is really limiting because it assumes that if 15% is genes, 15% is access to healthcare, then the rest must be what people do to themselves. And so our job is to just change how people behave. And, you know, that's what we do. And I'm going to try to prove that to you. This is really all about personal responsibility. Well, what we do in public health and government in general is we provide services. Because services are politically, basically, they're not controversial. There's a sick person, do something to help that sick person. And wait till that person gets sick. I mean, these services are remedial. They're not like anticipating sick people. They're just like, oh, she's sick now, now give her a service because now she's deserving of some governmental service. They focus on individuals, these services. They're remedial in nature. They almost never address the underlying environmental conditions. They're very expensive because they pay people like Larry, who's got a lot of degrees, to essentially design and provide these things, myself included. And we went to school, and we think that we are entitled to to earn a salary that pays us back for all the torture that we went through in school. The sad truth is that there is no evidence that this approach has any sustained impact on health disparity elimination. Yet that's what we do. And we don't just do it in health, we do it in social services, we do it in criminal justice. Let me try to prove it to you very quickly. This is the service armada in Alameda County. And I promised you 6 boxes. Really, if you wanted to follow the money, that's where the money is spent. It's spent downstream. 88% of our budget in Alameda County is spent in those 3 boxes in the healthcare budget.